position. Rise up, make that decision. God will provide all your needs. He wants you to succeed. Have faith of a mustard seed. Get up on your feet. Rise up.
Welcome to another segment of the Drexel SEMA show. This month is the month of the kidney month, actually. And so this show is dedicated to educating you about kidney failure. You know, it was in 2016 when I wasn't diagnosed with kidney failure in 2016. I was diagnosed with kidney infection many years ago. It was in 2016 when the doctor informed me that I had to go on dialysis. And that was a life-changing experience for me. And there's a lot of myths also about kidney failures, actually. In fact, I ran into someone over the weekend and the person say, "How you doing, Jax?" I said, "I'm well." He said, "Yeah, you're not doing well." I said, "What do you mean I'm not doing well? I hear you on dialysis." So there's a lot of myth. You know, you could be on dialysis and you could still be doing well. And so this show is really to educate people. I remember there's another instance where someone said, "I don't want my worst enemy to be on dialysis." And we have to be very careful what we say. And some people think, oh, because you are on dialysis, that means you're going to die soon, which I thought. And now it's been more than 5 years now since I've been on dialysis. But today I have Dr. Forbes, who's a nephrologist at the Cheshire Hall Medical Center. And we're going to have this conversation to educate all of us about kidney failure, the prevention of it. If you get it, what can you do? All these things. And so in honor of Kidney Month, I thought it'd be fitting to talk about, have a doctor, someone who's an expert in their field to talk about it. So Dr. Forbes, welcome to the show. This is not your first time. You came on before talking about COVID.
Right.
But this time we're going to talk about kidney failure. Welcome to the show.
Thank you for having me.
Dr. Forbes, you are a nephrologist, right?
Yes.
How long you've been now back in Turks and Caicos, and what did it take you to become a nephrologist?
So I returned to Turks and Caicos in 2014. So to become a nephrologist, first of all, you have to become a doctor. Mm-hmm. So I went to medical school. I went to the University of the West Indies in Jamaica. Okay. Prior to that, I did, some pre-medical studies. Mm-hmm. Once I graduated from medical school, I did my internship at the Princess Margaret Hospital in the Bahamas. Oh. And returned home to Turks and Caicos as a medical officer. Mm-hmm. I worked in Grand Turk mostly, but I also did stints in South Caicos and in Salt Cay for the day. Mm-hmm. Spent up to a few weeks in South Caicos at a time, along with Nurse Mills at the time. Mm-hmm. So that was a useful experience, but during that time I realized that we had a lot of chronic medical illnesses in Turks and Caicos and we needed an internist. Mm-hmm. So I went to the UK with the intention of pursuing internal medicine with a subspecialty. Mm-hmm. I was not 100% certain what that was at the time. But whilst in the United Kingdom pursuing internal medicine, I fell in love with kidney disease. Okay. It was a very hard placement. However, despite being difficult and having long hours, it was the most rewarding placement. Hence, I decided to pursue kidney disease or nephrology as a specialty.
Okay. Yeah. Well, I'm glad you did. I don't think we have any other Turks and Caicos Islanders, at least who reside in Turks and Caicos.
Not who reside in the Turks and Caicos.
Who are specializing in nephrology. Now, what is kidney failure?
Okay, so I'm glad you asked. Kidney failure, you can say that there are two types of kidney failure. You have acute kidney failure and chronic kidney failure. When I say acute kidney failure, it's kidney failure that ensues in a matter of hours to days or weeks. So it happens rapidly. This can happen due to severe infections, for example, or major trauma where you lose one or both organs. So depending on the cause of the acute kidney failure, persons often recover. Some persons recover fully. Some persons recover partially and are left with some underlying degree of kidney damage and go on to develop chronic kidney disease. However, chronic renal failure does not usually occur at such a rapid pace. It's usually a slow onset, it's indolent, it happens over months to years, and persons do not know that they're developing chronic kidney failure until they start to experience the symptoms. And that is usually irreversible, unfortunately.
And what are the symptoms of chronic kidney failure?
Right. So the common symptoms of chronic kidney failure can be due to fluid balance issues. Remember, the kidneys produce urine and help to maintain normal fluid balance in the body. So many persons with chronic kidney failure do not pass urine or do not pass enough urine. So they may develop fluid retention that can cause swelling in the ankles, in the legs, swelling around the eyes. Fluid can build up on the lungs and cause shortness of breath, what we call pulmonary edema. So those are some of the fluid issues. You also have symptoms due to buildup of the toxins, because the kidneys are filters. They not only filter, but they clean the blood, removing excess toxins, waste products of metabolism, drugs that people might take, and how those are broken down and the waste is removed by the kidneys. So the buildup of toxins can cause people to feel very fatigued. So that's a very common complaint. Also, loss of appetite. Some people then start to lose weight because they're not eating very well. Persons can have itching of their skin due to the buildup of minerals such as phosphates. Another reason for fatigue is anemia. The blood counts tend to fall because the kidneys are responsible for producing a hormone called erythropoietin. And that hormone stimulates our bone marrow to produce red blood cells to maintain normal hemoglobin levels or blood counts, as persons know it. So anemia is a common complication of kidney failure, and one of the symptoms of anemia is fatigue. So those are some of the main or the more common symptoms of kidney failure.
And of course, there's some people who do not have any symptoms at all, right?
Until they're tired until the very end, when they need to go into dialysis. They're tired and they don't know why. They cannot get up to move. They may have weakness. They may start to have the shortness of breath. But usually by the time you absolutely need dialysis, you're going to feel sick in some way. But a lot of people do have chronic kidney disease. So there are different stages of chronic kidney disease. You can lose up to 90% of your kidney function and have no symptoms. So if you wait until you develop symptoms to say, let me check out my kidneys, it's likely that you're waiting too late.
So what should individuals do then? I mean, should all individuals then, does this mean then that we really should get medical checkup, at least, I guess, twice a year? I suppose.
That is a very good question. So the good thing about kidney disease, chronic kidney disease, is that it's detectable through blood and urine tests. So persons who are high risk should definitely be having their kidney function checked at least yearly. There are persons who have diabetes, hypertension, heart disease, who are under regular medical care, and they really should be getting their blood tests performed on a minimum yearly basis. Most times, most persons may have their blood tests done probably 3 times a year or twice a year, but that depends on their particular condition. So there's no one size fits all. Once you perform your initial medical, then your doctor can advise you on how frequently you need to have your kidney function checked. But remember, it's not just a blood test, it's blood and urine. Because markers of kidney disease can appear in the urine before you see any changes in your kidney function on the blood test. So if you can detect it early and start treatment, you can potentially reverse that problem.
Okay, so you can reverse it if it's early.
If it's early, yes.
Because I think I was maybe 28 when I was 28, or 27. I think I was trying to get a mortgage.
Right.
And the bank requires medical.
Yeah.
And make sure the person's a medical fit
Sure.
before they give the loan, because if something happens, they want to make sure the loan get repaid.
Yes.
So you have to have life insurance.
Yes.
And so I did a medical checkup, and they discovered protein in my urine.
Right.
And so I went to the Bahamas to do a biopsy.
Mm-hmm.
And he came back and said I had this thing called IgA. I didn't even know what that meant.
Mm-hmm.
And so I just took that, and so every year I was checking, because the doctor told me can't give me a good medical record to take to the bank to get the mortgage. And so every year they would check, and they say, oh, your GFR, I think.
Yes, your EGFR.
Is at 40. And I didn't do no research. I didn't do any research. I just took it for granted. So if I knew now what I knew then, if I knew now back then, I think I probably wouldn't be on dialysis. I just took it for granted. I just rely on these medication that was being given. I didn't do no research on it. And until 2016, when I went to my final checkup, the doctor called me and told me that my EGFR is at 19%. And so I'm like, and then I say I may have to go to that. I say, well, then I start the research.
Yeah.
So I think it's important for us to check early.
Yes.
Because, like you say, it can be reversed.
That's correct. In the early stages.
In the early stages. So in addition to that early stage, even before you get a kidney, some sort of infection or disease, what can we do to prevent us from getting kidney failure?
Okay. Thank you. That is a good question. So if you're wanting to know how can we prevent this, then it helps to know what causes kidney failure. There are lots of causes of chronic kidney disease and kidney failure, but in the Western society, the top two causes are type 2 diabetes, or diabetes as a whole, and hypertension. 1 and 2. Okay? And we know in our society that diabetes and hypertension are prevalent. There are other causes such as heart disease, certain cancers such as multiple myeloma. A person may develop kidney cancer and need to have a part of that kidney removed or the whole kidney removed. And the other kidney may or may not have some amount of disease in it. Certain infections can cause kidney failure, such as HIV infection, hepatitis B, and hepatitis C. So, for example, if a person has HIV infection, it's not only important to take the medication and monitor the level of the virus in the blood along with the immune system, it's also important to monitor their kidneys, because the HIV infection can cause kidney damage, and some of the medications used to treat HIV can cause kidney damage. There are other medications that can cause kidney damage. Common painkillers such as non-steroidal anti-inflammatory agents, NSAIDs, ibuprofen, also known as Aleve, Voltaren, Advil. So these are names that people probably are familiar with and that a lot of people use for pain, but these can cause kidney damage.
Really?
They can, especially if you are already a high-risk individual and your kidneys are already under strain due to diabetes or hypertension, for example, then these drugs, especially if taken for longer periods of time, can cause kidney damage. So you want to limit your exposure to these drugs if at all possible. Certain drugs called proton pump inhibitors that we tend to use for gas or acid. Over time, those can also cause chronic kidney disease. So we just have to be very careful when we're taking medication, be aware of what the side effects are, and try to avoid taking medication you do not absolutely need.
But aren't the doctors are the ones prescribing these medications to us that possibly could cause kidney failure?
Right. So you're right. That's a good question. And all medication has potential side effects. So if you look up a medication reference book, for example, and you look at potential side effects, it's going to be a long list, 50 to 100.
Gotcha.
And then the frequency would be like greater than 10%, 1 to 10%, less than 1%. And then certain, and then so you have to consider, is the benefit going to outweigh the risk for this particular patient at this particular time? However, so what you need to do then is to say, what is this person's risk? If I have a patient with they know already they have chronic kidney disease, I would avoid prescribing certain medications for them that I know that can damage their kidneys, and I would advise them to stay away from those medications. And if you need to prescribe something, for example, some chemotherapy for cancer can cause kidney damage, but then you want to treat the cancer, but these chemotherapy agents are also toxic potentially to various organs. So you have to, give informed consent to say, well, this is the goal for treating the cancer, for potential cure. These are the potential side effects, and we would like to monitor you closely.
Got it.
So it's all a balance of risks, really.
Okay. So what is IgA? I think that's what it's called.
Yes, IgA.
I think that's what I was told. That's what I had.
Right. So the IgA nephropathy is one of a number of immune-mediated kidney diseases or glomerulonephropathies. So IgA is an immunoglobulin that's produced by your body. It's like an antibody.
Okay.
You have IgA, IgG, IgE. So there are various types of antibodies. But then sometimes the body may produce an excess amount of an antibody, or that antibody develops an affinity to your own organs. So antibodies are supposed to attack intruders and invaders, right? And to prevent you from getting infections. But sometimes the body turns on itself, the immune system turns on itself. That's what we call an autoimmune disease. The immune system turning on itself and attacking its own organs. That includes conditions such as IgA nephropathy, conditions such as lupus. That's an autoimmune disease, rheumatoid arthritis. So there are a number of these autoimmune diseases out there.
Okay.
Lupus is another important cause of chronic kidney disease that can lead to kidney failure.
Okay. Kidney disease, is it something that can also be inherited from your parents or grandparents?
That's a great question. You don't inherit kidney disease per se, but you can inherit genes or conditions. You can inherit certain conditions that set you up for kidney disease.
Got it.
So, and these include Alport syndrome. These include polycystic kidney disease. That's probably one of the more common forms where persons grow such large cysts, huge cysts on both kidneys, and these cysts overtake the normal functioning architecture of the kidney so that you don't have normal functioning tissue left, and those persons go on to develop kidney failure. And there are different types of cystic disease. Some are more dangerous than others. So you can develop a condition, you can inherit a gene that gives you a condition that can predispose you to kidney disease.
Okay, that makes sense, because I know of a friend whose child, I think was about 2 or 3, and was diagnosed with kidney disease. And then I remember when I went to the Dominican Republic to do a double check, get another opinion when it was too late at that time. I remember the nephrologist saying this 8-year-old just got a kidney transplant, and I was just amazed how young people were, experiencing this condition. Now, does diet also play a role in the prevention of kidney disease?
Well, certainly, if you consider that the top 2 risks are diabetes and hypertension, and diet plays a significant role in both of these conditions, either in preventing the onset, particularly with type 2 diabetes and hypertension, or even helping to keep these conditions under control, then diet plays a huge role in prevention as well as your overall care and maintenance of your health. Yes.
Any particular diet that we should take? I mean, I had the nutritionist, one of the nutritionists on my show, Lakeisha Wilson, and honestly, I never really heard about this, but it made sense. And she said, you have this plate, 9-inch plate.
Yeah.
She said half your plate should be veggie, quarter should be, I think, proteins, quarter should be carbohydrate. I never even thought about that.
The typical Turks Island plate is a half or 3/4 of the plate is starch.
And we haven't put any veggies on it.
Hardly.
So what kind of foods? As I know you talk about the diabetes, you talk about the hypertension.
Mm-hmm.
So what kind of food should we be avoiding then to help us on this journey, to prevent us being on this journey actually?
Right. So I would like to look at everything as a matter of balance.
Okay.
So rather than thinking about foods to avoid, you want foods what you should be eating more of and foods what you should be eating less of.
Okay. Fair
so
point.
if you consider that plate and a half of it is vegetables and a quarter is carbohydrates, then you're not eating as much carbohydrates as you would normally consume in the Turks and Caicos diet. There are several diets or many diets out there, but what you really want is a diet that is rich in vegetables and fruits, so a plant-based diet as much as possible. Okay, if you're going to have protein that's animal protein, then it should be lean protein. You want to minimize your exposure to red meat because red meat can increase your cholesterol. There's also increased risk of certain carcinogens that it can increase your risk of certain cancers. So increase your risk of heart disease. So red meat should be minimized. It's not something you want to eat every day or several times a week.
Good point. I know a lot of us who love our red meat.
Yes.
And red meat is like what? Spare ribs?
No, that's white meat.
That's white meat?
That's
okay,
pork.
so what's red meat?
Your steak,
Steak.
oxtail, that's red meat.
Oxtail is red meat?
Oh, yes.
Okay.
Goat.
Goat?
Yes.
Goat is red meat? Okay. Oh, I love goat.
So you want to minimize the intake of red meat.
Okay, so red meat. Okay, because right now I just focus on eating
Or
chicken
any
and
type
fish.
of beef.
I just do chicken and fish. Now and then I would get, goat and ribs.
Right. And then you have these cured meats. So we love our pigtail.
Oh, I love
Some of us, many of us in Turks and Caicos love pigtail.
Oh, yes.
But it is cured meat. It's high in salt, as you know, and salt can affect your blood. It can raise your blood pressure. So salt is bad for blood pressure, for high blood pressure. And then you also have the fat content. If you look at pigtail, it's literally fat covered by skin. So there's no nutritional...
I don't eat the fat part.
Then you're not eating pigtail. There's no nutritional value there, and that can increase your cholesterol. Fat is not broken down and eliminated by the body. It's broken down and absorbed by the body. So if you can see it on your plate, that's going onto you. So if you're happy with what you see in the plate becoming a part of you, then I wouldn't recommend it, but at least think about that.
That is interesting. But I mean, I have improved a lot, especially after that video with Miss Wilson. I'm very conscious now what I eat,
Yes.
So.
So nuts, legumes, those are, proteins, plant-based proteins. They're high in fiber and other minerals and vitamins. And then your starch, you want complex starches rather than simple processed starches. So try to stay away from sugar, the candies, the sweet sodas, the fruit juices, which are just sugar with a bit of coloring. Prefer to eat the fruit because you get the natural goodness of the fruit, but you also get the fiber from the fruit. And a lot of people suffer from constipation, but they don't want to eat the fruits and the food that gives them fiber. So, and that also helps to avoid certain bowel cancers and so forth. So a plant-based diet as much as possible. Stay away from processed food, cured food, simple sugars, red meat as much as possible. Limit the alcohol intake, because alcohol over time can affect your blood pressure, your kidneys, and so forth.
And even when you're on dialysis, you should still, because some people will say, well, the machine is going to, clean me. You should still eat healthy.
Oh, yes. Even more so, because, the machine is not a perfect replacement for a functioning kidney.
True.
Right? And but also persons with kidney disease have a higher risk of developing heart disease.
Okay.
And so there's that connection there. So you have to be even stricter. So you have to continue to look after yourself. So don't say, well, I'm on dialysis now, therefore I can just sit back and relax. You really need to continue to look after yourself in order to remain healthy on dialysis.
Yeah. Okay, well, speaking about dialysis, so at what point do the persons who have been diagnosed with kidney failure, at what point do they have to be on dialysis? Right.
So most people will start dialysis when their kidney function is around 10% or below 10%. That is usually the time when people are experiencing significant symptoms.
And that's stage 5.
Stage 5 kidney disease is when you're 15 and below, so you're less than 15%.
Okay.
So 15 and below is stage 5, but most people actually need to start dialysis because of symptoms of fluid buildup or high potassium levels once they're around 10% or below.
And then during the dialysis, a lot of people believe that once you're in dialysis, you will soon die. Is that true?
That does not have to be the case. That does not have to be the case. You know, people are living longer and longer nowadays on dialysis. And even in our local units, you've heard of persons living 15 years.
20 years.
And longer on dialysis. So it really depends on how well someone is looking after themselves, how well they are complying with advice and the treatment protocols. You know, our behaviors, our actions have consequences.
Yeah.
And so what we do, even if we're managing a chronic condition or chronic illness, how we manage that illness can influence how our journey through that illness.
And when you're on dialysis, you basically go there 3 times a week.
Right.
In
so
4 hours, right?
You are speaking about hemodialysis, which I like to describe as the blood dialysis. So yes, that is a typical prescription that most persons will have 12 hours of dialysis. And that can be broken down often from a scheduling point of view, 4 hours, 3 days a week. There are persons, again, depending on the availability of resources, some persons can do home dialysis or nighttime dialysis, but we're still talking about hemodialysis at home. So if you have a hemodialysis machine at your home, perhaps you can get away with doing 2 hours, but 6 days a week, for example. So, you know, there are other ways to manage a dialysis prescription, but it's about getting enough dialysis to clean your blood, to keep your vital organs functioning. There's also a peritoneal dialysis, which is a dialysis via a tube through the abdomen or into the abdomen, through the peritoneum, into the peritoneal cavity. And that is a home-based dialysis that persons perform every day, but at home.
And how many hours?
So there's more than one type of peritoneal dialysis. So you have a nighttime dialysis, for example, called automated peritoneal dialysis using a bedside machine that can fit on a bedside table or one of that size. And persons can be on that machine between 7 to 10 hours overnight whilst they're sleeping. So they can connect, go to sleep, the machine does the work. If they need to get up and go to the bathroom, there's an extension tube so they can go to the bathroom and still be connected to the machine. And then they come back to bed. And then they get up in the morning, they disconnect, you know, and they go about their day-to-day lives.
So basically so you have the 2 types of dialysis. But the other choice, obviously, for persons is a transplant.
At the moment, yes, a kidney transplant. That's correct.
And how is that process done? I mean, what involves in getting a kidney transplant?
Right. So there are 2 major types of kidney transplant. You have a deceased donor kidney transplant and a living donor kidney transplant. So many countries with a kidney transplant program, the most common type of transplant is a deceased donor transplant. So persons may sign up to donate their organs in the event that of their demise, okay? And so that person's organs are obviously tested, and then there's a matching system. So a person has died, they provide 2 kidneys to the transplant
unit
or to the transplant service, and then someone who's on dialysis or who has advanced kidney failure who matches that kidney that would receive a kidney transplant. Obviously, persons who are already on dialysis take precedence, they take priority over persons with advanced kidney failure. So that's the most common type of transplant worldwide. You have the living donor transplant, where a person who is alive can donate one of their kidneys. And that's because a person can have a normal life, a normal lifespan, okay, and live a healthy life with one good functioning kidney. So living donor transplants have been happening for decades now. So there's a lot of data on the safety of the procedure. And the person who wishes to donate a kidney, and you don't have to be a relative of the person with kidney disease. So the potential donor goes through vigorous checks. You want to make sure that, one, they don't have kidney disease themselves when you have different stages without symptoms. So we check that they don't have kidney disease themselves. And we also ensure that they don't have those risk factors that puts them at risk of developing kidney disease further down the line. So they go through vigorous testing to make sure that we're not putting that person in harm's way by taking one of their kidneys away. We also don't want there to be any coercion. We don't want people to feel that they have to or feel obligated. So there's that component as well. And we certainly discourage payment for kidneys. So in certain markets, and that's not something that's condoned by international societies, the payment for organs, that's not something that is condoned at all. But yes, a person who, once you are healthy and you have 2 functioning kidneys, you can donate a kidney to someone who's in need.
Okay, so what about the perspective from the patient? Because not everybody, my understanding is not everybody can receive a kidney, is capable of receiving a kidney, or shouldn't receive a kidney. Okay. So what do we, from a patient point of view, what does it take for that patient to be in a condition to be able to receive a kidney?
So the majority of dialysis patients would be eligible for a kidney transplant. Certainly some of the major things that we test for and that we try to ensure that persons are fit enough regarding would be their heart, for example, and their compliance. Okay, so let's talk about the heart first. As I said before, persons with kidney disease have a higher risk of heart disease than the general public. So we go through vigorous testing of the heart for persons who are on dialysis to ensure that their heart is fit to receive a kidney transplant. Some people have even required stents and then gone on to have a kidney transplant. So having a heart condition does not preclude you, but you want to make sure that you're in the fittest state possible.
Got it.
Because, you don't want complications developing after the transplant that were preventable and that can actually hasten your demise. And then, so that's one of the things. Another thing, I'll talk about compliance because that's really important. A lot of people, certainly in Turks and Caicos and perhaps in the Caribbean at large, are not, 100% compliant with advice or medications or their general health care. But compliance is really important because it influences your outcomes. So if you're prescribed blood pressure medication for high blood pressure and you're not compliant, your blood pressure is likely to be high most of the time or fluctuating. Neither of those are good. And both of those put you at risk of kidney failure or kidney damage, they put you at risk of heart attacks and strokes. And so if you're not complying, then you are putting yourself at greater risk of developing complications that could have been avoided. So compliance is really important in terms of your overall health. But certainly when it comes to a kidney transplant, once a person receives a kidney, our body's immune system recognizes that kidney that comes from someone else as a foreign entity. So the natural response or reaction would be to attack it. And so in order to prevent our bodies from attacking that organ, that engrafted organ, that patient, the recipient, takes drugs called immunosuppressants. So drugs to suppress their immune systems to prevent them from rejecting the transplant.
And so it's important for persons to take those drugs.
Oh, yes. So you can miss a day. If you are not complying, you undergo rejection. And that can lead to loss of the kidney. And so, again, you don't want to put the patient, the recipient, through a kidney transplant process just for them to take the immunosuppressant sometimes, or when they feel like it, or when they remember it. That kidney transplant will not last.
Yeah, I know, because we've seen cases, where that happens. You wonder what happened. It's probably because they're not compliant.
I'm not going to speculate. But what I'm going to say is that if a person is not taking their medication as they should, and even on time, then that leads to rejection and failure of the kidney transplant.
And that medication, I heard, is quite a lot.
It's quite a lot.
Someone talking about 80-something pills.
It's a lot of medication, and although it decreases over time, so the greatest risk of rejection is at the beginning, at the early stages, but you still require some medication in the long term. But the pill burden, the volume of pills goes down over time. It doesn't stop completely, but it does go down over time.
Because you need to continue. Right. So what are people that are obese?
Right.
What are their chances of getting, being able to get a kidney transplant?
Right. Okay, so obesity is not an absolute contraindication. It's what we consider a relative contraindication. And some transplant centers have a higher risk-taking culture than others. And perhaps I shouldn't say a risk-taking culture, but their protocols would then allow them to transplant persons above a certain BMI. But there's a limit to every protocol. Their body mass index.
Okay.
So it's pretty much your weight for your height. But persons who are obese, they are at high risk when they receive a kidney transplant. First of all, the surgery is technically more difficult. There are issues with healing. So there could be delays in healing, risk of infection, risk of diabetes even after a transplant. So a person who may not have had diabetes before the transplant can develop diabetes after kidney transplant. Wow. So you have to look at the balance of the benefits versus the risks.
Yeah. Wow. Now, in the Turks and Caicos Islands, we don't have a list where people can register if they want to donate a kidney. For those people in the Turks and Caicos Islands who want to donate a kidney, what is the process? Do the patient to look for those individuals themselves, and then where does the kidney transplant take place?
So that's a good question. So persons who would like to donate a kidney, you have persons who are altruistic donors. So for example, they may not know someone with kidney failure, so they may not have someone in mind, but they are interested in just giving away one of their kidneys. And that person can approach their regular doctor and say, this is something I'm interested in doing. What are my next steps? There are some basic checks that would need to happen to make sure that that person doesn't have chronic kidney disease that they were not aware of and assess their risk. So they should approach their doctors. Generally, although we have been trying to promote donor sensitization, persons are more likely to donate a kidney to someone that they know.
Sure.
And so persons with kidney failure are encouraged to have those discussions with people in their circle. There's also material online. There are lots of resources for persons who are interested in donating a kidney, because if they're considering the risk to themselves or potential risk to themselves, they're more likely to do that if they're connected somehow to that individual. So it is usually persons who have that condition reaching out to persons within their circles in terms to, regarding potential donation. If persons are interested in further information, then they can certainly contact the nephrology team, and we can also provide them with additional information about kidney donation.
Now, there are some patients who prefer remaining on dialysis than to get a kidney transplant because of all of the medication that they have to take that you described earlier. I mean, what do you say about that? I mean, I know it's a personal choice, but...
Yes. It is a personal choice. And then, again, it's a personal choice. Some people I've spoken to, for example, a few people who may feel that because of their age, in terms of life years, life expectancy, are they going to gain much going through that procedure and having a kidney transplant? Some people, everyone has their own reasons. And it's not going to be the same for everybody as to why they wouldn't accept a kidney transplant at this time. Sometimes it's just fear of the unknown or certain uncertainties. But again, it is a personal choice.
Yeah. And then people that have kidney transplant, the lifespan is about 15 years. I mean,
it varies. Have people, depends on how old you are. So there are children who receive kidney transplants. And so if you're asking the average lifespan of a kidney, the average lifespan of a kidney that has increased over time, you're looking at many kidneys are surviving more than 10 years nowadays. So if a very young person gets a kidney transplant, depending on their course, some people may need 2 or 3 transplants during the course of their life, especially if it's a teenager or a very young person getting their first kidney transplant. So it's a number of things. So yes, the life expectancy is improved with a kidney transplant. For many people, for most people, it's the quality of life. It's the freedom from dialysis. And certain dietary restrictions. It doesn't mean you don't have to eat healthily, but
restrictions are not.
And the fluid restrictions and so forth.
Well, Doc, thank you for this opportunity to have this discussion about kidney failure. Are there anything else that you'd like to cover while we're here?
Okay, so thank you for the opportunity. So anytime I have the opportunity to speak about kidney failure, chronic kidney disease, I always want to talk about prevention because, prevention, as you know, is better than cure. And a lot of people are walking around with risk factors for kidney disease or chronic kidney disease and are not aware of it. And people do not think about their kidneys until they're told by the doctor that you have kidney failure, that there's something wrong with your kidneys or you need dialysis. So I think as a country, where for the size of the population, we have quite a number of people with kidney failure, a number of people needing dialysis. I think we need to consider and we need to be more proactive. We need to consider our risks, consider our lifestyles. We need to look at our diets and try to move towards a healthy diet, more of a plant-based diet. We also need to get moving. A lot of us are sitting from morning till night, and the only walking is from the door to the car park, okay? So that means that we do need to make moving.
Interesting.
Physical activity a part of our healthy lifestyles, because this goes a long way in prevention of diabetes, prevention of hypertension, if you have those conditions, control, but also prevention of kidney disease, prevention of heart disease, okay? So the key is know your risk,
Mm-hmm.
get tested.
Mm-hmm.
If you don't, you have a family history, you have diabetes, hypertension, get your kidney function checked. So see your GP at your earliest opportunity to check your kidney status. Yeah.
Well, thank you. That was very informative discussion. You know, as I mentioned earlier, I'm on dialysis, and I hope that you are watching the show is that informed. I hope that you take your lives, you know, seriously. Don't take anything for granted, especially those of you who have diabetes or hypertension. They're like the two leading things that are causing kidney failures, because other things are causing it. But while it's okay to be on dialysis, I mean, I get a lot done. You know, your quality of life is still impacted. You know, because you are restricted. You have to be there at least 4 hours a day for 3 days out of the week. And nobody wants to be in the hospital, you know, 12 hours a week. Nobody wants to get stick twice with a needle. So if you could prevent these things, please try and do that. You know, and the easiest thing to do is to get checked up. Is to go to a medical doctor every year, or at least twice a year. Get a checkup. Check your kidneys, because you do not know. Some of you don't even know that you have high blood pressure. It's a silent killer. So it's important for you to get a medical checkup and make your decisions from there. And every year get a medical checkup. And you could increase the length of your life. You could also have a better quality of your life. And so I encourage you today to take this interview seriously that we just had with Dr. Forbes. And I hope that it makes a difference in your life. So please, you don't have to be in the state that many of us are in. You don't have to be in dialysis. And the earlier you're able to detect this, the better you are. Thanks again for watching the Drexel Steamer Show. Remember to subscribe to my YouTube channel.